Greetings and welcome to the Heywood Healthbeat, a program that's designed to help you understand and explore some of the most significant health issues that our community faces. Today, my guest is Selena Johnson. Selena's a project manager at Heywood Hospital. She's into just a bunch of different things, some really important stuff, creative things that I think Heywood Hospital has been doing to really increase and supplement and enhance patient care and outcomes. So let's talk a little bit about, we talk about building projects, we talk about infrastructure, and people see the hospital as that building place that they can get services. But they don't often know or understand some of the special or new initiatives, innovative things that are happening at Heywood. So let's explore some of those. Now, a few years ago, we first got acclimated, kind of introduced to each other through your work with the CHART grant. Mm-hmm. What was the CHART grant and what were the goals of that project?
Sure. The CHART grant tested care delivery and really brought to life in a medical setting how we can work with our patients as a whole person. So we looked at not just what they came into the emergency room with and their diagnosis, but how are they in their living situation? Do they access care appropriately once they leave the emergency department? Are they housed properly? Do they have issues with transportation? Do they have issues accessing medication, housing? How is their behavioral health? Are they looking for services? And we really looked at care coordination beyond the incident that brought them into the emergency department. So it was really a whole person view of care, which is a new segment for healthcare. And one of the exciting things about being part of Heywood Hospital and part of this region is that we are forward thinking and that we're looking at new advances in how we can care for our patients.
It's really interesting. You talk about kind of looking at what's happening in that patient's life beyond the diagnosis or complaint that they're coming into the hospital with. What are the types of things then that the people at CHART would do to enhance services? So you say, geez, we explore things like transportation, we explore things like access. Mm-hmm. What's the next step? What did they do after that?
So what we were testing was really a staffing initiative also, having immediate services, removing barriers to care, allowing people to access services where they needed it and when they needed it. So within the ED, we had behavioral health therapists directly there. So if someone came in with a behavioral health concern, issue, problem, we had people on staff that could engage a patient differently and not look at them just as a medical diagnosis. So it's all about how we approach patient care and look at the patient. From that point on, then we also had community health workers as well as the clinicians to help people access care. A lot of people, when you're in the emergency room, it's a stressful environment. You're already struggling with some issue, and then hearing all of the things that you have to do to take care of yourself when you're leaving with 3 pages of paperwork on how to take care of yourself, what your medicine is supposed to be, where you're supposed to go, and everyone just kind of yeses you. Okay, let me go. What we did was staff it in a way that we follow up with people. We help them understand along the way, each step of the process, what their needs or how to access care could be. And we have someone there helping them. So they'll follow up with phone calls, they'll do face-to-face visits. They did case management in a very different way, not just a referral, but we really helped people link to services and overcome barriers.
I think that's, particularly an important message for people to hear, because I think that sometimes the general population don't understand the complexity of accessing care, the complexity of follow-up to significant diagnosis. And so having somebody there that can do maybe a little bit of the hand-holding, that connection to those resources they need. We just went through some training, and one of the things we talk about is active listening, and it's interesting to know that in a normal kind of environment, somebody only hears 25% or less of what's being said. So they're not getting the whole message. That must be particularly complex for a patient who's coming in with a significant diagnosis or a significant pain issue, whatever that is, and then being given these, huge volumes of information for a part of their continued care. It must be very difficult for them to really be able to process that, to acknowledge that, and then to put a plan into place to follow up with that care. So it seems to me like the people from CHART really played an important role in the outcomes and ensuring that the outcomes were positive for patients with complex medical or behavioral health diagnosis.
Yeah, and something else that we did beyond just working with the one patient and what their barriers or accessing care was to look at who is connected to this patient along their continuum. Where are their doctors? Where are their specialists? Who are they seeing outside of our services at a medical center? And help link with those providers so that we were all aware of and all supporting the patient holistically and not trying to both do or all do similar things and really streamline the work and support the patient.
So much is going on with regard to medical information and patient portals and information highway to ensure that all practitioners get information, vital information about the other care that patient may be receiving, but it is still slow and it's still cumbersome and it's sometimes difficult to manage. And so having somebody that can really talk to provider, talk to what that patient is going through and the services they're receiving, I imagine is a really good thing for a patient who sometimes thinks, why the heck am I doing this? I already did it here. Or, why do we have to do this 3 or 4 times?
A lot of times we call the community health worker the champion or the advocate so that they could speak with the patient, not necessarily on behalf of the patient, but help that patient kind of navigate their way through the system. And navigator is another term that's used quite often.
A lot of good work happened with CHART, and we have both kind of statistical and anecdotal feedback on the improvement of the care that patients received under CHART. But like all new initiatives, that was our test, and that test evolved into something more. The next kind of phase of enhancing patient care was our care coordination project or program. Tell me a little bit about that.
Sure. From care coordinating in the emergency room, we also looked at care coordination from a slightly different angle. Again, I think we're lucky being where we are. Our hospital system looks beyond their medical facility and looks at the community. So we have great partnerships with some school districts and great partnerships with some provider agencies in the area, and we are helping to bring in services and care coordination where it's very difficult to access. So looking at behavioral health, we're in a provider shortage area. There are more people seeking behavioral health services than there are providers for, and it makes it very difficult and cumbersome. So parents trying to navigate and identify how to access behavioral health care, how to access support services, they were really spinning their wheels and a lot of times just frustrated. So students may be misbehaving, parents may be misbehaving, all looking for support services. So what we partnered with the schools was to bring in a community health worker, which we labeled school-based care coordinator. It's really the same position, to be embedded in the school systems and to be a partner with the community and to be a partner with the students, the families, the teachers, the administration. And we helped to identify students that may be in need of services or families that may be in need of services and have someone easily accessible on their terms, working with their family to say, how do we process through these barriers? What are your needs? And have someone on their side to access services.
Yeah, that must be huge for a family of a young person in our community who's trying to access services for those people. Like you said, resources are scarce in North Central Massachusetts. They exist, but they're scarce. I mean, there may be providers, but providers' offices are closed. They don't have any room for new patients. That is particularly difficult to have somebody there that can champion that cause for them, that can help them navigate sometimes a very complex mental health and behavioral health system and navigate the physical health.
And the insurance aspects. There's so many diverse angles within insurance that it's extremely difficult to understand what your benefits are and how to access something, and then what type of red tape you have to go through in order to get what you deserve as a parent or as a student or child. One thing that has been a wonderful benefit in partnership is that we're seeing attendance improve. We're seeing, negative behaviors dissipate. We're seeing grades improve. So it's been a nice, partnership in bringing the health of the community to a higher standard, and hopefully creating stronger individuals that'll give back as adults. So we're looking to really support the youth, not just here in Gardner, but across central Massachusetts. We have school-based care coordination programs in several of our school systems, really to be an advocate for the school, to be an advocate for the students and the families, and to help access cares, because again, we're in such a reduced access region that it's difficult to support all the needs.
So tell me, what school systems have the school-based community health workers?
So currently we're at Gardner. Okay. We have a school-based health center at Murdoch and Winchendon. We have people in Athol, Royalston, a couple different schools there. We're in Marhar. We're in Narragansett.
That's a huge saturation.
We're very broad-based. Some of them are doing multiple things, not always functioning in the same capacity. At a couple locations, we're looking at telehealth, telebehavioral health, because of the ability to really bring a provider to where the students are in a region that we have a provider shortage. So doing it through telemedicine is eliminating the need for transportation and bringing providers that are skilled to this region where, again, we're in a shortage. Other areas, we have providers from local agencies or on staff that go to the school and provide services there. And then we also work with external providers. So there are many wonderful agencies in this region that will now come into the schools, provide services, help us coordinate with them, and also some private individuals that never considered going to where the population is, and they're now opening their doors and coming to where the need is.
That's been a huge shift that I've noticed in both primary care, physical care, and mental health and behavioral health, is that we realize that one of the major barriers for people receiving the care they need is transportation, is access kind of in total to those services, access, availability, access in terms of just simply being able to get there. And so providing the services in the place where those people are most likely going to be makes a lot of sense. That just really just sounds so obvious, but it really isn't that obvious. It's not something that healthcare has really done well in the last 20 years, last 100 years, and now we're seeing this huge shift. You mentioned telehealth. That sounds interesting. What is telehealth? How does that enhance services? What does it do? What is telehealth?
So it's basically the same thing as sitting with your counselor and having a session, but it's done through a monitor. So we're in a world of technology, and people are on their phones all the time. And what we're doing right now is working with youth. So it's a natural connection for youth right now to be on their phones and texting or FaceTiming. It's a very comfortable source of communicating. Sure. What we're doing is looking at what's going on in the world, what's going on nationally. Here are these services, and can we bring something to our region that will help us with this barrier access? So telemedicine is one of them. Telehealth is doing behavioral health counseling through technology. So we have a provider at an offsite location at their own office. They have a module in front of them that they're speaking to, and they can see the student from. The student is in a private room, also logged into a monitor and speaking to the television screen or the monitor screen, or sometimes doing a drawing activity, but having a session with their therapist through almost a FaceTime component, but it is a locked feature. It's not something that is easily accessible for
Right.
others. It's still a very, very private modality, but it truly is something that has allowed students to access behavioral health care in an area that they never were able to before.
We're going to talk a little bit more about this because I find it intriguing. One of the things you said earlier was that we live in a deprived area in terms of providers, especially in the mental health, behavioral health arena. And so telehealth is more than just about convenience. It's more than just about providing an opportunity where it's easy. It's about providing an opportunity to access to services that might not otherwise be available for these young people.
Yeah. That's the key piece of it. That is really what brought our opportunity to the region, is that there is the barrier of access, and that's clearly what we're looking to address here, is to say we deserve access, we deserve high quality care, and what's another avenue for us to bring that to our region.
How successful has telehealth been?
Extremely. The school systems have been very open and very receptive to it. It has fit into the style of the schedule very, very well. Our clinicians have seen a lot of success with doing this, and the families that are participating have also expressed a lot of success with the capacity too.
Well, you mentioned earlier as part of this project there were 3 major milestones that you acknowledge have been affected. Academic performance, attendance, and behavioral problems. Those are 3, I think, huge issues for school systems when they're trying to address some of the underlying problems that kids are bringing to school and that affect their ability to be successful and thrive in a learning environment.
Yeah, and one thing that I did not mention was kind of the cycle of the program. People are referred in, so a parent can suggest or request their child to be serviced. If there are behavior problems, a teacher can identify, someone in administration can identify. So there's multiple ways to suggest or request that a student or patient be viewed, but the parent is always the final.
Well, yeah, let's
So
really
we
emphasize that.
We reach out to the family, we include the family in everything that we're trying to do. We talk with them about what our services entail, what it's like. They can come and meet the clinicians. They can come for telehealth and also see what the system looks like. But the family is at the heart. And we look to not just support the student with their behavioral health, but then we also look at the family and what is there that we can help them with. There may not be anything that is required, but they are the heart. So we need to keep the family engaged, and as with everything that we do, there's always a permission factor.
Folks, let's just reiterate that the school-based community health workers are there as a resource and an advocate for students in their community, but it's not done in isolation of the parents. Any referral for service, any connection to service, any follow-up service always requires the consent and authorization of the parent. So it's really a collaborative effort between the school system, the school-based community health workers, and the family. I think that's a really important piece to make sure that people understand, so they don't think that maybe services are being provided without their knowledge or consent. That's huge. All right, so we've talked about the school-based community health workers, which I think are significant, and we may come back to that. Heywood is doing some other things in our school systems and with our school systems to really try to link better those services. And one of the major initiatives that have rolled out in the last couple months is the Handle with Care initiative. Tell me a little bit more about Handle with Care. First of all, what is Handle with Care, and why would Heywood endorse or support Handle with Care?
Sure. Handle with Care is basically a community response to supporting children that have been impacted by trauma in some capacity. And it's really looking at how we, as the adults and leaders of the community, respond, and we could either positively influence or negatively influence a child's life. Handle with Care, what we're looking at as a health organization is, again, as a community partner, working with our police department, our school department, and then eventually rolling out through the EDs and the pediatric department and our local agencies, how we can wrap around and support our most vulnerable youth at a time that they're struggling. So what we're doing right now is identifying the school districts that we're in currently. It was a natural identification, so we have school-based care coordinators or community health workers in the schools, working with the police departments, and really looking at the cycle of information. I'm struggling. I'm sorry, that was really hard for me.
Cycle of information. No, that's important. I think first of all, the
It'd
first
be better
thing you
if
mentioned.
I could express it.
Yeah, well, it seems like it's a complicated and complex initiative, and I think that people need to know and understand that it's not meant to be, a simple, quick fix, but it helps. And I think you talked about the cycle of information. It really helps enhance that cycle of information. Oftentimes teachers, child care providers, people who are involved in a kid's life kind of intimately and in terms of a lot of time, and they don't know when something's happened. So the kid may show and manifest behavioral problems or academic problems or social problems that the teacher or the child care provider has no clue, what's going on because of some kind of trauma. And so trauma is very personal. I think we need to know and understand and recognize that too. It's
Right.
very personal. It can be.
So trauma within this is really everything and anything. I think a lot of times it's natural for people to think that it's always a violent trauma,
Right.
or that it's a domestic violence, or that it's a drug-induced activity. It could be police responding to a parent having a heart attack at the home. It could be a car accident. It could be displacement due to a fire or some action that has impacted a youth, a child. And I think a lot of times we don't necessarily look at the collateral damage of what a traumatic experience could be. So the trauma is never occurred to the child. They're a collateral piece of what's happening in the world around them,
Right.
that they have no ability to control or have direct impact on. So a police officer would be responding to a situation. Maybe it is a domestic violence, or maybe it's a car crash in front of the house, and they're seeing the result of the ambulance following up with patients that have been severely injured. But there's a child there. What they're going to do now is in their reports, police are very, very adamant and very keen on identifying what are those factors in a situation. Well, now they'll identify, okay, there was a child at this location. They will then identify what school district does that child go to, because when this person goes to school in the morning, they might have other affects and other behaviors that we should be aware of. We should handle this person with care. So they'll work with their police department, find out who the school resource officer is, give an update to them just to say, handle this child with care. No other information is shared. They have no idea about
Wow.
why we're saying this, what the child was a part of, just that they were a part of something in their life at one point that really was beyond the normal scope of their activities. So handle them with care. The school resource officer then reaches out to the school system. Usually it's to 2 or 3 pre-identified people, one always being the school-based care coordinator or the community health worker, the superintendent or principal, or sometimes a guidance or a nurse. Each school district is identifying their key people, and they will just get a notice, handle this child with care. No other information is shared because it's not necessary. The school does not need to know what details has happened in that child's life, just that be observant. If they're exhibiting behaviors that are a little bit more radical or much more pulled in, it's because they had something traumatic happen in their life. We're not saying interview this child. We're not saying become a social worker and try to do therapeutic intervention. Absolutely nothing. What they should do is be more gentle, be more kind. And this is something we're trying in our life no matter what. And as a school system, really learning about, how to not impact or
In a
worsen.
negative way.
Yes, a negative way, because it would be so easy when you have a frustrating child and you're in class to just send them to the principal's office and respond negatively also, which really is the opposite of what we're trying to do.
And it sounds like doing those things, which, you know, historically, if we think back when we were in school, there wasn't really this kind of trauma-informed environment. And so when a child has experienced something, you know, really significant in their life, consequential, and they are showing that or manifesting that maybe in a behavior that isn't acceptable to a teacher, the normal reaction might have been to punish that child, either, again, by the principal's office or discipline, you know, detention or suspension, a failing grade on a test, you know, no grade or failing grade on a homework assignment. So this idea of kind of zero tolerance for, you know, for not doing the things you're responsible for. And now we know and understand that there's complex things that are happening in our community that significantly affect that child's ability to learn. So that sounds like it's a really cool response. And we'll go through that system again. So handle with care, some kind of trauma happened. And by the way, actually, we're going to back up a little. You know, why do we care? Why do we care about that trauma? Well, I think you mentioned earlier to reduce the number of significant negative after effects that you know may happen innocently, right? Just because people didn't know. So increase the amount of knowledge that people know quickly, as opposed to waiting 2 or 3 or 4 weeks, months, or years before finding out something significant. And we also know the impact of trauma on a kid's ability to learn. That has a toxic effect. It changes the chemical reaction, and these toxic chemicals then affect adversely brain development and their ability to, you know, remember things and process things, not only academically but socially. It affects their social interaction. So it's important. It's not just a feel-good project. It's an important project that really speaks to the long-term benefit of the child. So that's kind of cool.
Yeah, an added piece to Handle with Care, which by the way is not a new system. It's been in existence in the United States in different locations for several years. But what we're looking at doing is adding or highlighting a component, because we have so many community health workers already embedded in our school systems, that when child with Handle with Care is flagged, that we also then look back at the family. You know, there needs to be a response. Are they displaced? So, you know, Red Cross might help with a night or two at a hotel, but what other needs are there for that family, and who can they rely on to help them? So we're looking at what is that care coordination modality that we can add to it when or if interested. Again, families can always say, we're all set, we don't need anything else. It was, you know, a difficult night or two with Granny's heart attack and we were in the ED, but we're okay. To, you know what, I think we as a family need some support services, and we now have the ability to help connect them. So it really is looking at strengthening not just the child, but being very focused on the child so that they are healthy and in school and learning, but also the family and connecting with them.
You know, Handle with Care comes with some costs and resources are needed. What are some of the organizations or agencies that have stepped up to support the Handle with Care initiative in North Central and North Quabbin?
So we have a grant currently through the AGO, the Attorney General's office, and it's to really develop the outline and structure of what Handle with Care could be for a community. It's supporting a lot of the trainings that we're bringing in through resiliency, ACEs. We're doing trainings with the schools, trainings with the police department. So it's a really strong backbone. But you're right, there's always a fee when it comes to doing something like that. We're also doing our 5K. We have an annual 5K at Heywood Healthcare. It's now going to be designated to supporting Handle with Care, and all the funds that are raised from the Healthy Harvest 5K will go towards supporting Handle with Care in the future. We also have a grant from DCU, and DCU is helping to support, and they have always been a strong advocate for children and behavioral health.
That sounds like a really strong partnership. So you're bringing in, you know, a lot of different organizations. We'll go back to the structure of Handle with Care. We talk about ACEs and adverse childhood experiences that are predicated from a traumatic experience, adversely impacting the child's ability to learn and thrive in a academic environment. One of the other pieces I understand are childcare providers. Tell me a little bit about how childcare providers fit into the Handle with Care model.
Sure. As part of our AGO grant, we're partnering with Mount Wachusett Community College. So it's been a great addition for us in looking at how we can sustain some of these impactful ways. So when we're looking at how we become a trauma-sensitive community, and we're working in the school systems, we're doing training so that their staff will continually be at the front line of how do we work? You know, how do we impact students? How do we impact their life? How do we support Handle with Care so it becomes systemic in the school system? We're also looking at our educational facilities that are teaching that next level of teacher, or that are developing our up and coming leaders. So we're working with the Mount on developing or instituting a component of trauma-informed care or ACEs, whatever we want to call it, into their curriculum, as well as, okay, so these are our professionals. They're the people that we trust on a daily basis to teach our children, but what about our youngest children that are not yet in the school system? They're at daycare facilities, whether they're the large daycare facilities that have a lot of exposure to trainings, or the smaller, home-centered daycares. How do we work with those really important people in our children's lives at such a young age? So the Mount is developing a curriculum to really support those early childhood educators, because they're key in the instrumental development of the children at such a young age. So we didn't want to leave out a segment of the community that I think a lot of people don't look to as influencers in child development. So early childhood education was a key focus that the Mount wanted to bring in and really build, going forward, a stronger continuum.
That makes a lot of sense. You know, we know that childhood trauma, when it occurs in a youth's very young ages, 3 to 5, has much more significant impact long-term, well into adulthood, on behavior and mental health. So connecting those folks with the Handle with Care project, letting them know when something has happened so that they can do the things in their setting to ensure that that kid is supported and provided the resources. And that connection also is made with our early childhood educators, our child care providers, to our school-based community health workers, so that those people can get, the professionals in those centers can get the support they need to provide resources to the family and for that child.
And a lot of times if there is some traumatic event and there is a family that has a breadth of kids in it, so they have, a preschooler versus a 5th grader, these early childhood centers will be engaged from the very beginning. So to leave them out would be a huge miss when it came to
catastrophic, I would imagine. Catastrophic. So lots of good things going on. The care coordination seems to be really at the heart of all of this, is to have some people that can help our youth and their families navigate the complex system of primary care, mental health, and behavioral health. And so it really seems to me like those are the spokes or the hub of the wheel, not the spokes of the wheel, that really drive these initiatives.
Yeah, I think personally, care coordination is a hidden factor. We always think of referrals, and people will get a referral and they'll get the service that they need. But even the people providing the referrals, if we're at school, guidance counselors, they have so much on their plate that being that person to make all the referrals becomes overwhelming. Some of the strata of need is so deep that they might not necessarily know how to even provide a proper referral for some things. Flip side, if you're working in the pediatric department and you have a family that comes in that has a plethora of need and a lot of specialty services, you don't have always the time or the resource to dedicate to help care manage some of your patients to accessing, you know, the needed services, or helping them with all the barriers and the red tape that it takes to get there. Sometimes it takes a couple months to go through application processes, and it's very easy and understandable why some families just stop. So I think the care coordination piece and having that champion, having that advocate for the family really is a key factor. But unfortunately, it's one of those factors that for the most part is non-reimbursable. It's not a factor that can easily be sustained, because you're trying to justify, well, you're a paper pusher in a lot of sense, but it's not the reality of who they are. They do a lot of education, they do a lot of outreach, they do a lot of follow-up and championing for the family that is not reimbursable. So it's a role that I think is very difficult for sustainability. But when you look at the outline and the design of a program, almost any program, it's a key position in really ensuring that something gets done.
You talk about not being reimbursable. Let's explain that to our audience a little bit better. What does not reimbursable mean?
So a lot of the services that are provided, whether it's clinical, mental, behavioral health pieces, your insurance is tagged. So they're paying for it. So it's reimbursed. So the services that a provider is giving is reimbursed. So they're getting paid. Yeah, a physical, a clinical intervention, a therapeutic session, a lot of that is paid for. Even some of their time, paperwork-wise, is paid for. But this provider, a community health worker, is not doing a clinical intervention. Therefore, it's not paid for by your insurance. It's a position that's doing necessary and required work that really helps people access services, but not on the insurance dime. So it's very difficult for us to have a budget stream that supports positions where there's nothing coming in on the backside to help support the position financially.
I think that's just such an important thing for our viewers to know and understand, is that there are a lot of services in the community that enhance or provide connection to those critical and complex physical, mental health, and behavioral health services that afford people the opportunity to be successful and to live long and healthy and you know, and good lives, good quality lives. But for case coordination, those people are never connected to these services, and case coordination is not reimbursed. Now at Heywood Hospital and Heywood Healthcare, we have a real commitment to providing those types of resources that help people connect to the type of services they need. But that is not necessarily long-term sustainable. And telehealth, I think, is another one. And so I want our viewers to know and understand that there are a lot, you may be able to deal with the complexity of a system, you may be able to navigate it, but there are a lot of people out there who can't. And they need the support of community-based health workers and case managers to assist in that endeavor. And the same thing holds true with telehealth. Now, telehealth is not reimbursable.
Telehealth is just on the cusp. So we were allotted a grant a year or so ago to really look at bringing telehealth to Massachusetts. It's reimbursable in other states. It was not reimbursable in Massachusetts. It's a new venue. So we were looking at kind of the challenge of what kind of interest is there, how would insurers look at this, what is the system. So what we're doing now is really at the forefront as an advocate to say this is a very important service, especially in a provider shortage region, bringing this telemedical piece to our community is necessary. And we're now at the Capitol and we're being heard, and we're part of a movement to really make it a reimbursable piece. So I think if it hasn't already, it's very much on the edge and next to be reimbursed. Will it be for all services? Maybe not. But we're at the forefront to bring it there. And we're also now looking at including not just the youth behavioral health, but family sessions through tele, and then also looking at and considering, can we do some sort of intervention when it comes to addictions And is that something that we can do reimbursable through telebehavioral health? And the state is looking at us, and they're on our side, and hopefully we'll be able to make some wonderful changes there when it comes to advocacy, so that it becomes reimbursable and becomes a more permanent solution to the deficit that we have here.
Well, it's a complex environment. Healthcare is a complex environment, and I hope that folks that watch this show know and understand or get a better appreciation for sometimes how difficult it is to provide services, access services, and be able to do the things that we need to do to keep ourselves healthy and safe, and for our kids to keep them healthy and safe, and our families. Lots going on in Heywood. Again, you mentioned a couple times that many of these initiatives are new and they're innovative. They're not being done anywhere else. And Heywood's at the forefront. And I think that that's a very important message for our folks to hear, that as we look to expand our physical plant and are continually improving on technology and the physicality of how healthcare is delivered, we look at a lot of the other programmatic and service-oriented stuff. Always new, always exciting, always different, meant to just improve the quality of life for the residents of North Central and North Quabbin. So remarkable stuff going on. You're doing a great job. It must be an interesting job to have, always changing, kind of something new all the time. Thank you for taking the time to be with me here today on the Heywood Healthbeat. Ladies and gentlemen, we have been talking today with Selena Johnson. Selena is the project manager for Heywood Hospital and does and coordinates a whole bunch of different initiatives that I hope you have learned a little bit more about. If you want more information about Heywood Hospital, please go to our website, www.heywood.org. Follow us on Facebook, like us on Facebook, follow us on Twitter. Thank you, ladies and gentlemen. It's been a pleasure being with you here today.